hyperplasia, maybe PH. What does that mean? It means enlarged prostate, right? Okay. Now, why is that important? Okay. I gotta find. I had a picture somewhere. What did I do with my picture? There it is. Okay. So why is that important? Okay. Why is the enlarged prostate because an issue? Where does the prostate sit? Sits right under the male bladder. And what runs through the prostate?
The urethra.
The urethra runs through it, right? Okay? So right under the bladder and the urethra runs through it. Okay? So when that thing becomes enlarged, what's our biggest problem? What's the biggest thing that happens? Because of what? Can urine flow through the urethra like it normally can? It cannot. And you guys know my rule, right? What does not go forwards goes backwards, right? So we have now where we have a lot of urinary retention because the urine flow stream is not normal, right? So why does this pose a problem? Because where was the urine going to go? It's going to go back up in the bladder, and your bladder can only hold so much, right? True? True. And what also happens when urine just sits in the bladder for a long period of time? We can now create infection where now we got UTIs in place, right? Okay? That can eventually result in urosepsis, okay? So, yes, so that's so what are the signs that we're going to see for that? Things like what? You think they're going to complain about being able to get the urinary stream started? Yeah, right, okay, because now we have now condensed down, the urethra is now much smaller where that prostate is at, it can't actually get started, right, okay? They're going to have a very weak urine stream, okay? They may have where they can kind of have some, where they can urinate some, and then they're going to have to stop because guess what? Not as much is flowing, and then they got to start again. Okay? They can even have some dribbling once that urination is complete because guess what? That urethra is not completely emptied out. They're going to complain of a lot of urgency and frequency, right? What's urgency mean? The feeling like you got to go all the time, right? Okay? And that frequency is going all the time. Okay? And then, of course, they can complain of having to go to the bathroom and urinate a lot of time. Okay, so a couple of things. PSA screen, all right, prostate-specific antigen screen. We talked about that the other day. I mentioned that the other day. That's done how often? Every year, usually for about males above the age of 40. And what we're looking for is trending, okay? So that if they go every year and it's normal, what I'm looking for is it elevating, okay? Because if it keeps elevating or if it's already extremely high, that's an indicator of what? Possible what? Prostate cancer, or it's an indicator that they're a higher risk. So as it continues to elevate every year, it means, hey, we might have to watch them a little closer, okay? The other thing is they have to go in there and the physician will do a digital rectal exam, okay, to kind of feel that prostate and see what if it does still enlarge, okay? Okay, so some things on there, all right, some things on there that we can do. So what would you do? Okay, first of all, how would you know if your patient was retaining urine? What do you think? So, do you think they're going to probably have some symptoms? What do you do when you feel like your bladder's full? Do you hurt? So they're going to have pain over the bladder area. It's going to be, it's like, you've ever had that where you can't hold it no more and it hurts so bad, but then you can't go, okay? So they're going to have that pain. They're going to have those urinary symptoms, okay? They're also going to have, you could do a bladder scan. Anybody ever done a bladder scan before? Yeah. Okay, it's got this little thing and it's got this little picture and you basically hold it over the bladder area, kind of like you would an ultrasound, and it's going to put out this report and show you how much urine is in that bladder. Is that pretty handy? Yeah, because if I did a bladder scan and it said, well, you got 100 mils in there, is that a problem? No, our bladder's pretty big, right? We can hold quite a bit on there. But if I did it and it said I had 1,500 mils in there, is that a problem? That's almost a urinal full or more, right? Okay? So that's how you can tell how much they have in there, okay? Now, how would we fix that? How would we fix that? If your patient is retaining urine, what's the solution to that? We can do an in and out catheterization, right? We don't want an indwelling. Remember, an indwelling is what we call a Foley. An indwelling stays in there. So if they're just having urinary retention, we don't want to put in an indwelling urinary catheter Foley to sit in there because of risk of what? Infection. But if they're retaining urine, we can go in and we can do an in and out cath. It's just, have y'all done that at freshman? Did y'all practice in and out cath as freshmen? Okay, it's just one little tube. You go in there, we drain all the urine out, we pull it out. In and out very quickly. Now, why is that a decreased risk for infection?
It's not staying in there.
Because I'm not leaving it in there. So I still use sterile techniques, so I don't compromise the bladder, but it's not just sitting in there to let bacteria grow on it, right? Okay? So we can do an in and out cap. The other thing that we can do is we can start them on some tamsulosin. Okay, some tamsulosin. You may have heard this on TV. Notice Flomax. Okay, how does tamsulosin help? What's it going to do?
It's a muscle relaxer.
It's basically like a muscle relaxant. Okay, tamsulosin. I want you to think that tamsulosin feels like a muscle relaxant. It's going to relax that muscle around the bladder and the prostate gland. So if it relaxes it, what's it going to allow it to do? It's going to allow more urine to flow through the urethra. We actually prescribe this to women as well. Why would we prescribe this to women? Come on, you're getting close.
Kidney stones.
That's my girl, that's right there. Kidney stones, right? Because why would this help even patients with kidney stones? It's a what? It's a relaxant. So if it allows things to relax, is it going to allow more urine to flow through the urethra? Absolutely, especially when you're trying to pass a big stone, right? Okay, so that's all we're doing. So now, let me ask you this. So we want to take it in the morning, and the reason we want to take it in the morning is why? So I'm not up all night, but am I going to get more benefit of having this thing work all day? Yeah, I don't plan on being up peeing all night, right? That's not my goal. But if I take this in the morning, is that supposed to help me all day with my urination process? Absolutely. So is it more effective if I take it in the morning because then I get to use it, what, all day, right? If I'm in bed, this isn't helping me none because I don't plan on being up peeing all night, okay? So we want to take it in the morning. The other thing is it also can cause orthostatic hypotension, right? Okay, so you have to teach your patient orthostatic hypotension, meaning what? What do we teach our patients about orthostatic hypotension? So we're going to go from a lying to a sitting to a standing very slowly. If they start feeling dizzy or lightheaded, they need to sit down, right? All of those things. What other things can help improve the decrease in the risk of orthostatic hypotension? Remember our causes. What were our three causes? Remember volume? So patients that are dehydrated or hypovolemic. So if we also increase our fluid intake, it will help minimize the effects of the orthostatic hypotension, right? Okay? All right, now, how would you know that the tamsulosin is working? So I'm going to have a better improvement in my urine flow stream, right? You're going to go, yeah, I got a lot better urine stream when I go in there and go to the bathroom. And what's that going to result in? Better what? There will be no pain, but if I got a better flowing urine stream, I'm going to have better what? Urine output, 100%. That's how I know this is working, right? Okay, fantastic. Okay? All right. Now let's go on and talk about the TURP. Okay? So the TURP, known as the transurethral resection of the prostate. Not really as much of a resection as it is a cleaning of out. Okay? So what they do with this is they actually insert this scope into the urethra, right? And they're going to go up the urethra all the way up here into the prostate, okay? And basically they got this little tool that they're scraping like a bunch of excessive tissue out from around this prostate area, okay? Why would that be beneficial? Why would that help your patient? Because what's it doing? I'm cleaning out the blockage, I'm cleaning out the trash, which will then kind of help widen up that urethra where now urine can flow, right? So I'm going up in there and I'm cleaning out the debris and the trash to allow the urine to flow from the bladder down the urethra. Make sense? Okay, now let's think about this. I'm going to go up in there, I got this little tool, and I'm going to be scraping out all this excessive tissue that I don't need. And anytime I do any scraping on tissue, what's going to happen?
Inflammation.
It's going to bleed. And what happens when it bleeds? It's going to do what? It could what? I can hemorrhage, or it can also do what? Clot. Okay, both. Okay. So what we do after a TURP is when the physician goes in there and scrapes all of this excessive tissue out, what else do you think happens? Think there's going to be some swelling? Oh, yes. Now, what would happen if that thing swelled shut? I'm not going to have any urine output, right? So what do you think we're gonna do? What do you think the doc's gonna do when they're in there doing this procedure? They're gonna put in an indwelling urinary catheter known as your Foley, and it's gonna stay there for about 2 to 3 days. Why is he gonna put that why is the doc gonna put that catheter in there for 2 to 3 days? To allow the swelling to go down and allow my urine to flow, right? Do I wanna risk swelling or a clot getting in that urethra? No. Because it will completely obstruct it off. So I put that indwelling urinary catheter in there, and it's gonna stay there. So your patient a lot of times will either stay in the hospital for a couple of days, or they'll send them home even with that urinary catheter for a couple of days, and then they'll have them come back to the clinic and they take it out. Yes?
Will the catheter not irritate it more?
Okay, so there's probably going to be, it's not going to irritate it more. It may be some discomfort because of the surgery itself on there. That's what's going to create the irritation part, okay? But if you don't put the catheter in and you allow that urethra to completely obstruct from either the swelling or blood clot, we're going to have no urine output, and then we're going to have a problem because we can actually rupture the bladder. Yes?
Would that be when you want to use CPI, or would that be just regular? Like, would you want to do bladder irrigation?
Getting there. Atta girl. Yes, I'm getting there. So a lot of times what we do with these patients in the hospitals, when they come to me, okay, so Mari's the nurse taking care of patients that just come back from a turf. What's one of the first things that you're going to look at? Patient comes back, are you going to see an incision? No, because we ran this tube up through the urethra, right? Okay? So we're not going to see, but am I going to probably palpate bladder area? Yes, because I want it to be soft, right? I don't want it to be hard and distended, and should they have a lot of pain? No, they should not have a lot of pain, right? I don't want anything to indicate that I've got bladder holding in there. What else am I going to look at? They're coming back to this indwelling urinary catheter. What am I going to look at? I want to look at the urine that's in that bag. I want to look at that urine that's bag. What am I looking for in the urine that's in that bag? I want to know the color and the consistency. Do I expect it to be kind of pink tinged?
Yes.
Yes, we just went in there and went to scraping around this tissue and causing all kinds of trauma on this man, right? Okay, so I expect it to be pink tinged. What do I not want it to be? I don't want it to be bright red, and I don't want to see a lot of bloody sediments. So what Amari is talking about is a lot of times those physicians will order what they call continuous bladder irrigation. And what we do is just like an IV bag, it's this big, huge gallon bag of saline and there or sterile water, and we run this, it's basically where it'll run down and the tube actually connects to the Foley catheter where we can irrigate it, meaning we can run that saline or that sterile water into the urethra, because that's where's the Foley sitting at? The Foley's sitting up there towards the bladder, right? We can run this saline or this sterile water up into that bladder, and then it flows the other direction out back into the bag. Why would we want to do that? Come on, removing what? I'm removing any clots, any sediment. Is it going to keep it from becoming obstructed? 100%. 100%. So they'll order that continuous irrigation because I'm trying to prevent clots from forming. I'm trying to prevent sediment from sitting in there and obstructing that urethra, that bladder area, right? So very, very good call, Mari. Somebody else had a question. Mandy, you have a question?
I did, but you answered it. I was
Fantastic.
wondering when they were going to place the catheter.
Yeah, they actually do it
In surgery.
In surgery. So same thing. Let's talk about that. If it's in surgery, we take it out? No. We don't take anything out. If we have a problem with it, patient goes in there, and I know this sounds kind of gross, but I've actually had them confused before. They took that whole thing out, bulb in place, and you go in there and they're swinging it around the room or they're chewing on it and all these other things, right? Yes, I have had that happen. Do you try to put it back in? No. Because of what? We're going to have some swelling. So do we need, odds are they're going to have to go back down to interventional radiology and probably have a place. What you got, John?
So this PowerPoint makes it look like it's easy peasy, 1, 2, 3, like a process, but apparently it's so, the cost benefit analysis can be so skewed in the other direction that like they let old men just have prostate cancer for 15 years because of the risks of like erectile dysfunction and incontinence and stuff like that. So like, how do you
I guess
decide?
Help me on your question. Decide on what? Whether to do this?
Yeah, to go in here and do this if like it seems like the guidelines now are right to like let a 70-year-old man just have prostate cancer for 15 years, because that's not going to be what's killing them or causing problems.
Well, so here's the thing, okay? If our treatments for prostate cancer have changed, we treat prostate cancer just like we do any cancer. We could do surgical intervention and remove prostate. We could also do things like a chemotherapy. Okay, I've seen now where a lot of y'all learn about that target chemotherapy, right? Where they take pills. They really take pills as their chemotherapy part. Okay, so I think that what we're learning is that some of our other treatments for this type of cancer are being more effective, or can be more effective than running the risk of this. I actually see, I used to see Turks all the time. I don't see them as much as now, and you're right. I think we're just trying to try other things versus this process right
I'm just
here.
seeing that big old void on this picture up here, it looks like, well, that's just gonna let urine just run out.
So, well, I mean, yes. So, but I mean, and to be honest with you, sometimes it's not always, depending on what the prostate looks like, it's not always effective. We can't always remove what we need to remove, okay? And here's the other thing too, though. This is a lot of times where things can be misconstrued. If a patient is gonna go in for a surgery, what do you think some of the things that rule them out the most from even being qualified to have surgery?
Age, comorbidities,
More
medication.
comorbidities than anything. If you have a patient that has significant respiratory disease or significant cardiac disease, okay, that they don't think can tolerate the anesthesia itself, that a lot of times will rule them out. Because here's the thing, they can go in there under general anesthesia and they're gonna be in there on a ventilator and we're gonna be ventilating them. We gotta think, when we're done, can we get them off this thing? Can we get them off this vent and extubated? And that's a lot of times, can their heart tolerate the procedure, right? So I've seen a lot of times where patients are excluded from procedures or surgeries just because of their comorbidities that come with that. So, okay, yes?
I'm just wondering, it's probably a silly question, but if the scope is going in there and scraping, does it not? Just kind of excess tissue,
Well, they're gonna go in there with the scope, when they have a scope, because it's a camera, they can see what's in there, right? And they're gonna scrape out what they can get a hold of that minimizes the risk. They're not gonna go in there, if it's something that's completely where they can't get, they're gonna get what they can safely, but it doesn't minimize the risk of the fact that they can puncture the urethra. They can, okay? And you gotta think about that, okay? So let's talk about that. What do you think would happen if they punctured the urethra? Would you probably see some of that? What do you think would happen if you saw that they punctured the urethra and were leaking urine? So things are gonna be more like a peritonitis, right? Because we're leaking urine out. So you're gonna be monitored for things like fever, increased abdominal pain, distension, things like that, because that does run a risk. It does, okay? Now, they are going to actually go home, like I said, they'll be in a hospital a couple days, they'll go home with that urinary catheter in place, and then a lot of times they'll have them come back to the clinic for a follow-up about 3 days out later. Depends on the doctor, usually about 3 days is average. And then they'll look at, what do you think they're gonna look at before they decide to pull it out? They're gonna look at that urine, how much is coming out, what does it look like, do we have any clots, do we have any issues? If things are great, they pull it out. If things are not great, they may have to leave it in longer, okay? Because like I said, sometimes when you pull that thing out, you're not getting another one back in place, okay? Okay. Yes.
Everybody get the bladder irrigation or only if it's needed?
In my day, most of the time we all have them coming back with bladder irrigation. A lot of times though, sometimes like they may hold off and say, what would you do? How would you know if a patient needs one or not? Because I've actually had them before, they come back and they have the urinary catheter in place and everything looks great, and then I start seeing a buildup of like sediment in there or kind of more some clotty type stuff, and then they'll order it. So sometimes it depends on your doc. It depends on your doc. So, okay, let's talk about erectile dysfunction. Okay, everybody ought to kind of know where this is going, right? Okay, so, all right. The biggest thing with erectile dysfunction that I really want you guys to hone in on is when we talk about the pills, right? We talked about the pill medications, right? Okay, what is the purpose? How does the pill drugs help with erectile dysfunction? It increases blood flow through what? Vasodilation, right? Okay, so that's the key part. This thing causes vasodilation, okay? So, if you were going to have a patient that came in that said, hey, I think this is what I need to roll with, okay? How would you know if this patient qualifies for this?
They have cardiac problems.
So what am I going to ask them?
If they have other like
Okay, so I'm gonna kind of hone in and go like, okay, let's look at your diseases, right? Have you had heart problems before? Maybe you had high blood pressure before? Have you had coronary artery disease? And all of those questions are gonna lead me to what?
What medicines are on?
What medicines are you on? Because what am I looking for? I'm looking for nitrates, any kind of nitroglycerin, right? And why is that a problem? Because what does nitroglycerin do? Vasodilate. So if I got this medication that causes vasodilation and I'm taking nitroglycerin that causes vasodilation, what's going to happen? I'm going to do what to their blood pressure?
Tank it.
I'm going to tank their blood pressure. I'm going to drop their blood pressure out significantly. And why does me tanking their blood pressure into the floor going to cause a problem? Because what happens to my cardiac output if I have no blood pressure? Decreases cardiac output, which then tissue organs do not get blood, and they will die, right? Okay? So very, very important, okay? The next key piece to that is that we teach these patients while it may work like they need it to, it may work really good than what they need it to. Y'all think I'm playing? I've had these come in the ER. Okay, if they have an erection for longer than 4 hours, why is that a problem?
Lack.
Okay, I got all this dilation and it's
Fall off.
Sorry. Well, I'm where you're going with this. Yes, the end result's probably going to be something's got to happen, right? Okay, but what happens is because I got all this dilation on there, I don't have it. It comes to a point where I don't have good circulation. Okay, blood isn't getting where it needs to be. And then I don't have oxygenated blood. And what happens to tissue when you don't get oxygenated blood? It dies. So it'll actually destroy that tissue. Okay? So a couple things. You can tell them that if the erection lasts more than 4 hours, they can put some ice, they can try ice packs. Put ice pack on there for 10 to 20 minutes at a time. Maybe they need it, and then kind of give it a little bit of a break, let it warm back up again, and then try again. But usually after a couple rounds of ice packs, if it ain't better, they're going to have to go to the ER. And they are not going to like coming to the ER, but I promise you they will, okay? I promise you they will, okay? Because when they get to the ER, how do you think we take care of that problem in the ER? About to get a needle and I'm about to start pulling out some blood out of that tissue, right? Yes, I'm about to help that thing out, okay? So yes, I've actually seen before, I thought I had seen poor male patients about have a meltdown. That doc comes in there with that needle and he's like, you're going to do what? Yes. Okay. So also, what would this be called? What's the fancy word for a prolonged erection? Cryopresin. Cryopresin. Yes, absolutely. Okay, fantastic. All right. We are tracking on the same page there. Okay. All right. Let me think. Prostate cancer. Not really anything on there. Same thing. The difficulty in the urine flow in the weak stream. That's anything that obstructs that urethra that's causing any kind of swelling around the prostate area, such as the cancer tumors. That is what we can, and that's why we also do the PSA on there. Okay. Same thing on the prostate cancer, though. We treat it just like any other cancer. There's all kinds of medical treatment things that we're doing for prostate cancer now. So, but I do like where you're going with that because there are, I don't know what the rate of prostate cancer is, but it is a high mortality rate for men. Yes. Yes.
Question about prostate.
Yes.
I know someone who has it and they offered to remove the prostate, but he was like, no, I don't want to do that. Does it, what happens when it's removed? What is it, does it cost?
I could think that I think that there is going to be some kind of downplay. Like you're going to have to go benefit versus risk. And when you're talking to a male patient, it kind of, that's kind of, I don't know, die or what? It gets kind of like, wait, that way the benefits versus the risk here, and you can't really, blame them for that. But yeah, but and actually a lot of insurance companies, before insurance companies would not, John's talking about, insurance companies wouldn't even pay for PSA screening until they were like 65. Why on God's earth would you wait till they were 65 to just do a blood test? It's a blood test. Then they moved it down to like 55. Then they moved it to 50. Insurance companies are learning it's a lot cheaper to pay for this blood test than it is to have to pay for all the treatment afterwards, right? Okay, so now they've even moved it down to around 40. So we're learning that earlier is better to kind of track those trends. In fact, when I was a brand new grad, that is how I learned how to become very good at phlebotomy and drawing blood. I went to work for this level 1 trauma center as a new grad. I'm working on med-surg board. But part of our residency, new nurse residency program is they had us slotted for days to do PSA screenings. So I would draw blood on 100 patients a day because they did that as a community wellness type deal. So it's just a simple blood test, not a big deal. So I agree with John, we've got to find a way to be a little bit more proactive on this. Okay, all right, breast cancer. Okay, here's the important thing about male breast cancer. Breast cancer is breast cancer, okay? Breast cancer is breast cancer. It can happen in men and it can happen in women. I do have a rule. Where's it at? It's over here. Nobody's bothered to tell me anything about this. Man, oh man. All right. So the thing about breast cancer is that it's in men and women. The treatment is really pretty much the same, right? We can do a mastectomy where we can remove the breast tissue that's affected, and they can do chemotherapy as well, okay? So it's really important to teach your older male clients that they kind of do the same thing, that they kind of do those monthly checks on their breasts just like women would, okay? I actually knew an elderly male client that had breast cancer. So not too long ago, I had my horse vet out. This man has to be 80-something years old, okay? He's an old school vet, love him very much. He has to be in his 80s years old. And I said, you know what? I said, hey, I hadn't really seen you around in a while. I said, what's been going on? This dude's tough as nails. He actually got struck by lightning when he was like 16 years old, horseback. Killed the horse, didn't kill him, but knocked out his hearing. So I was like, okay, you got 9 lives you're working with or what? So then, now, I asked him, I said, I hadn't seen you in a while. What's been going on? He said, well, I got breast cancer. And he looked at me and I said, what? And he said, I know, I'm like 2% of the population. And I was like, okay. And I was like, well, how did you discover that? And he's like, one day I just happened to notice I had this little bump I thought was just kind of a cyst there. He said, so I went to my doctor because it wasn't going away, and I kind of thought they might just need to go in there and cut it out. So he said, I made a doctor's appointment. I want them to just go in there and just cut that thing out, right? And he's like, so he goes in there, and he's like, so they check it, and then they scan him, and they think it's cancerous. So then he goes, so then they sent me for a mammogram. And I'm thinking, well, how does that work? Because the machine comes down this way. How does that work? I'm not real sure. Do they have them lay a different direction or what on that thing?
Turn the machine at like more than
I have no idea. I mean, I'm sure tech knows how to make that work. But they had sent him for a mammogram. And then they decided to biopsy it. And then sure enough, when they biopsied it, it came back cancerous. So they went in there and that's what he said. So then he's like, then I had to have a mastectomy. You know, he's just upset because he just can't believe this is happening to him. And so they removed the breast tissue, they removed some lymph nodes around it, and then they started him on chemotherapy. And he was tolerating it very well. And I told him, I said, well, they can't take you down. I mean, I was like, struck by lightning at 16, 80-something, got real breast cancer. I have no idea. But the treatment is really the same. So let's talk about that. What are some key things about the mastectomy that we know of? We can't do what if someone has a mastectomy?
Blood pressure.
We can't check blood pressures in that arm. We can't do blood draws in that arm. We don't need to start IVs in that arm. We need to roll with the other one, okay? I actually had a patient one time. She was kind of a more, she was more of a holistic type medicine. She didn't really believe in Western medicine. So she was taking all these herbs and stuff. She'd been diagnosed with breast cancer. She was taking all these herbs that she thought was going to cure the cancer, and she denied all the other treatment, okay? And I'm not, no lie, I was in both breasts, and these things were rotting off. It was like rotting flesh that I had to take care of these wounds. And I've never seen anything like that in my life. But it literally, huh? Oh, sideways. Okay, yeah, there we go. That's interesting. But there's no smashing involved. It doesn't look, or it smash comes up in there. Gotcha, okay. But these things started rotting off because of the type of cancer that she had, okay? So it's important that you understand that type of mastectomy care. Same thing, men need to do the same thing for preventative checking every month to make sure that's on there. So, okay. Testicular trauma, okay? Testicular trauma is exactly what it says. Anything that's going to traumatize that testicle area, okay? the biggest thing is that you know kind of how to take care of it, okay? So like with any kind of tissue trauma, they can take NSAIDs, right? Because that's going to do what? Help with pain and inflammation, yeah, okay? They can apply ice packs on there, 10 to 20 minutes. What's the key thing about putting ice packs on? We don't put the ice directly on the skin. We need to put a little paper towel or something, or a little paper towel or a napkin or a bed sheet or something to kind of cover between that. Yes?
Can this lead to the 4 years being
Can this leave anything that causes tissue disruption, that causes tissue necrosis can lead to any type of gangrene. Anything that will kill off tissue related to poor circulation can lead to that. I'm gonna tell you, has anybody ever smelled gangrene?
Yeah, it's
Woo!
gangrene last week, or actually Wednesday. It was
Gangrene.
inborn gangrene.
You will never,
His
ever
testicles?
forget that smell.
He had gangrene on his testicles? No.
So what was the cause of it?
On his foot. Okay. It's, okay.
Well, the
So
diabetes
she
already
said he
made
can get
it
it.
risk anyway.
But you can see his like shaft and his testes
No,
there.
just
It
kidding.
was rotting
Meat
off. There
and
was
muscle.
necrosis.
Really?
On his shaft.
Was this the guy just being really angry and ugly to people?
No, he was, that was another person.
Oh, another patient. There was one the last time I was up there. There was one up there that people were like, "Whoa, this dude
And
is
then
like."
his abdominal was tunneling.
Yeah, you stick your finger all the way up in there.
Good experience for you. Good
Great
experience.
move back.
I've never seen personally any type of testicles or anything like that rotting off. I did have a patient one time that went all Lorena Bobbitt on her husband.
Oh,
Cut it
no.
off. Yes, yes. Yeah, she found out that he's been stepping out. So when he went to sleep.
As she should.
And he came in there, and I'm like, what am I supposed to do with this? Like, I'm like, I don't know what, I don't know what I'm supposed to do with this. You know, I mean, because there's some major issues with that, right? I mean, we still got to allow the bladder to be able to flow. Now we're going to have to put in a suprapubic catheter to allow the urine to flow out of the bladder to the outside, kind of like an ileostomy, okay? Because we got to avoid that area. No, it's filled without circulation. But the good news is we do make prosthetics these days, okay? So that we do make prosthetics these days. But I felt bad for this poor man, because I mean, she just cut that. I thought, oh my God, I thought she just, man, woo! I thought she took it to the extreme. So, all right. So ice packs, you know, antibiotics, definitely if there's any kind of wound exposure, we gotta have on antibiotics, and a scrotal sling. Okay, you can actually buy these things on Amazon. They make amps, scrotal slings, okay? If not, you can actually take some towels and kind of make a sling. The whole purpose of it is to kind of relieve the pressure. So if you kind of elevate and relieve the pressure, it will help with the pain and the swelling. That's the whole purpose of a scrotal sling, is to kind of be able to relieve the pressure. Okay, let's do that. Time that pretty close to lunchtime. Here's what we're gonna do.
Lunchtime.
We're gonna break for lunch for there you go. And what's in the red blood cells? The hemoglobin, right? So break down the red blood cells, hemoglobin. Okay? That all becomes very apparent when we get to sickle cell. Okay? Alright, so we've got this down, right? We have to have hemoglobin to carry oxygen to our organs, to the bloodstream. Okay? Alright, now here's the thing. All hematocrit is a percentage. Okay, it's a percentage of hemoglobin. So basically, if you take hemoglobin and multiply it times 3, that's your hematocrit. So they usually will fall in suit, right? Hemoglobin, hematocrit usually will fall in suit. If one's low, the other one's low. You ain't gonna see one low and the other one high, because the calculation of hematocrit is just really 3 times the amount of hemoglobin in a percentage. Okay? All right, here we go. Okay, so let's talk about iron deficiency. Okay, now we just said how is iron important? It's the what? It's the heme and hemoglobin, and hemoglobin is the oxygen, all right, and the red blood cells that go to the organs. That's why iron is so important, okay? We have to have iron to meet the body's oxygen needs, okay? So we're talking about iron deficiency. Wouldn't you think you would see things, so when you think about iron deficiency, you would think about signs of what? That your patient is not oxygenating well, right? Can they carry oxygenated blood? So like fatigue. If you're not carrying oxygenated blood, you think you're gonna be pretty tired? 100%, right? Why would that pale color, you think I'd be pale? Absolutely. I would be tachycardic. Why would I be tachycardic and tachypnic?
Because your body's on compensate.
Because I'm trying to compensate. Absolutely. Okay? All right, then you can get to this. What's the glossitis? Inflammation and irritation of what? Of the tongue and mouth. And this cheilitis is just irritation and soreness around the lips. Okay? All right. So the key piece here is that low hemoglobin and hematocrit levels, all right, can be caused by iron deficiency anemia. Okay? Now here's the thing about hemoglobin. Okay? When you guys see test results, when you look on there and you're looking up lab results on there, and we give you these ranges, okay, let's think about what's relevant, okay? So if for a male's 14 and a female's 11.7, so let's say 12. Let's say 12 average, okay? If your patient had a hemoglobin of 10, are you worried?
No.
It's just a tad little low, right? Tad little low, okay? But is it enough to make you think they need blood? No. Okay. But let's say that they started up there at 15. Let's say they were at 15, okay? And then you drew it again because they had a GI bleed, and it goes down to 12. And then you're thinking, and then the next day, you draw it again, it goes down to 9. Are you thinking this is definitely getting concerning?
Yes.
So then that's when the doctor's going to go, hey, we probably ought to, let's type and cross. Let's draw a type and cross so that we can have some blood ready to roll if we need it. Okay, we've got to get the type and cross done. And then they'll put in an order that'll say transfuse if it's less than 8 or less. And then they'll put that order in. Okay? So why is that important? Because it tells us if we're losing blood, am I able to carry enough oxygen to the organs? Because it ain't there, right? It's not there. So that's why hemoglobin is so important, not only in monitoring blood loss, but as well as things like iron deficiency anemia, okay, because of the heme. Okay, so how would we fix this? Diet, right? Can we fix this with diet? Yeah, okay. All right, so what's some good sources of iron? Meats, especially red meats. Dark green leafy vegetables, things like your spinach, your turnip greens, your broccoli, right? I like some good turnip greens now, okay? All right, so I ain't a spinach person, but I like some turnip greens. Kind of weird, because they're about almost one and the same. But what about some beans, right? Some dried beans, okay? Now here's the key. If you're consuming iron, this only works if you take some vitamin C with it. Why? Because it's going to help us absorb it. Doesn't do any good for us to eat iron or take iron if we ain't going to do something to help absorb it, right? Okay? So we need that vitamin C. Where do we most commonly find vitamin C? Citrus fruits. Absolutely, citrus fruits. Okay? So, all right, glad we're clear on that. Okay, now, we can take iron supplementation, right? There are all kinds of iron supplementation, okay? We can take, this ferrous sulfate, which is actually a prescription. Okay, looks like these little dark maroon looking pills here. Okay, they can come in a liquid form. We have chewables. Okay, so there's all kinds of ways. Why do you think, to be honest with you, why do you think it would be really good for kids, like in the Flintstone vitamin, to have iron? What do kids not eat? They don't want vegetables, and they're not usually meat eaters, right? Unless you're talking some chicken nuggets or, some pizza, something like that, right? Okay? So we have to kind of supplement with that, okay? Now, a couple things, all right? So we want to try to go with oral supplementation first, right? We talked to them about diet. We want them eating meats, green leafy vegetables, citrus fruits, right? Okay, got that lined out. All right. Now, when we come talking about we're going to take some iron supplementation, we We wanna try to roll with some pills, right? Oral's fine, okay? It's best absorbed on an empty stomach, but what's the problem with that? It's gonna cause some GI upset, right? It can irritate, it can actually corrode, it can cause corrosion of the GI tract. And why is that? What is corrosion of the GI tract gonna cause? Ulcerations, which leads to what? GI bleed, which can lead to perforation, absolutely, okay, so that's a problem. So if your patient is having a hard time taking it on an empty stomach, they can take it with food, okay? And the key thing is that you wanna make sure that you teach them about signs of GI bleed, right? Okay, signs of GI bleed. The other thing is it may turn that stool a darker color, such as a green or a black color. Is that normal?
Yes.
Do we worry about that?
No.
So do we need to tell them, it might turn your stool black or green?
Yeah.
Yes, that is normal. We don't do anything about that. What is the other most common side effect of this? Constipation. How do we prevent constipation? Increasing fluids and what else? And if we need to, we can go with a stool softener. A stool softener is different than a laxative, okay? A laxative is going to have a little bit more of an aggressive approach of getting things moving, whereas a stool softener is going to do just that. It's going to take that water, it's going to absorb it, and it's going to make that stool soft. Hence why drinking water helps, because where's the water going to be absorbed? In the stool, okay? Down in that lower GI tract is where the absorption takes place, okay? So making sure that we try to prevent the constipation, because what happens with constipation? We get to obstruction, and what happens with obstruction? We get to perforation or a dead bowel, and perforation causes peritonitis. Yes?
So, if we give them oral iron, can we tell them increase their dietary intake of iron? Can they ever have too much? Like I know with calcium or potassium, you said that.
I've never seen an iron overdose ever in my career. And the reason is why. So let's think about that, okay? So heme, which is in the iron, okay, is in a red blood cell. Do we keep those same red blood cells for forever?
No.
No, they eventually kind of just done and over with, and we make new ones, right? And how often does that happen? There you go, every 120 days. So we're steadily, constantly, so that's what I'm getting at. You are never, unless you're just some crazy person that is like, if you, I guess, would eat the whole bottle, that could probably cause a problem, right? Okay, see what I'm saying? Not just in your normal. You can eat normal healthy foods of meats and vegetables and fruits, and then take this and not be. Who do you think, what population do you think probably is usually given an iron supplementation? Oh, what kind of women? Pregnant women. Why? Because now you got two taken up that's needing the need, right? Okay, so that's actually something that a lot of times, I don't know for those of you women that have had babies, but every time I had mine, and when I rolled in for my appointment, they checked my iron and my hematocrit every single time I went, because do I have to have oxygenated blood for me? And I sure need it for the baby, right? Absolutely. Okay, because who gets it first? Who gets what first? Baby gets it first, and they still take it from you. Okay, I had 18 years. Okay, I had one of them almost kill me. No lie, and she's still trying to kill me. Okay, so yes, I actually had preeclampsia. I actually developed PIH pretty bad, and I had preeclampsia, and I had to be admitted for an induction, and I stayed in the hospital for 5 days. My blood pressure ain't went down since then. She tried to kill me. So, but yeah, so, all right.
Our OD told us hanging a bag of iron when we play is like, it's like a nail or two worth.
Really?
Like eating a nail.
Really? Oh, yeah. Well, and that is true, because like when you can give iron IV, and like I said, you got to be really careful when you're giving some iron, some IV. I tell you what makes me nervous. Have you guys seen some of these wellness clinics that are offering different types of supplementation? Like you can go in and you can get yourself some vitamins, IV injections of vitamin fluids. You can get yourself some iron, you can get yourself some B12, and that really makes me nervous. Because I'm like, you got people going in there just because they feel better by doing it, but I'm like, and then what's going to be the effects of that? You know what I'm saying? What's going to be the long-term effects of that? Those kind of places make me kind of nervous for that. So, all right. So another thing, they need to take it with a full glass of water, right? Okay, so full glass of water. They don't need to lie down for, they need to kind of sitting there for at least 10 minutes. If they are taking a liquid, you gotta shake. Why would you shake any liquid bottle of medicine first. Because what happens? It settles what? You think it's gonna separate? Yes, osmosis makes things separate, right? You ever done that when you made yourself a glass of iced tea, right? And then the ice melts into water? Where's the water at? The water's on top. You ever notice that it's really light colored up here and really dark at the bottom? Same thing that's happened. It's the osmosis going to separate the medication from the liquid it's mixed in. So you always want to shake it. That way it's fairly concentrated, okay? And then anytime that they are taking liquid iron, you want them to drink it so the straw can actually stain their teeth, okay? And they don't like just drinking it by itself. It tastes nasty. So you can mix it in some juice. Orange juice is usually pretty easy to mix it in. So, but no, they need a straw so they don't stain their teeth. Okay, so let's talk about iron injections, iron replacements. You can actually get this by IM or IV, okay? You need to be very careful, because like he said, if you're getting an IV dose of iron, it's about to be strong, good stuff coming your way. Strong, good stuff coming your way, okay? So if your patient starts having some dizziness or some flushing, you need to slow that rate way down so they can tolerate it, okay? Because you're hitting them with a pretty heavy dose of it, okay? Now, because it can actually cause fatal reactions. They can actually have a pretty severe reaction to an IV. So you have to monitor them with an IV. If you give it to them IM, it has to be by the Z-Track method. Have you guys, did y'all learn this as freshmen? About the Z-Track method? Okay? So how does the Z-Track method work? What do? You're just gonna pull the skin back, right? You're gonna pull the skin back, you're gonna give the injection, and then you're going to release it, okay? And the whole idea of it is so that it gets deeper. See what's gonna happen? If I give the injection down here deeper and I pull this out of the way, when I put that tissue, all right, so let's look at this. Okay, if I pull it back out of the way, you see how the needle goes through this tissue right here into the muscle? Yeah, okay? And then guess what? Am I gonna poke a hole here? Yep, I'm gonna poke a hole and I'm gonna make a hole all the way down to the injection. So when I pull it back and I release it, the area where I made the hole, is it covering over the area of the muscle where I had a hole? Is it covering the area? No, it's separate, right? Why would I want to do that? So that what doesn't happen? So it doesn't leak back up into this tissue. And why would I want to do that? Because of what? I don't want it to cause some tissue necrosis because that medication is strong. It could cause tissue necrosis. So where do I need this medicine at? In the muscle? Do I need it in the tissue? No, I don't want it anywhere near it. That is the whole point of a Z-Track, is so that the medication gets in the muscle and it doesn't leak back up into the tissue because it can be harmful to the tissue because of how concentrated it is. Okay? All right, let's talk vitamin B12 deficiency. When you think vitamin B12, what are you thinking? I like the vegetarians in it. Okay, but what do you think? What do you think of when you think of foods for vitamin B12? Proteins. B12 and proteins should link together for you. Because then if you think B12 and proteins, what kind of foods are you going to think? Meats and what? Eggs, fish. Yeah, there you go. So B12 and proteins should link together for you. Now, why is B12 important? Okay? B12 helps with red blood cell formation. What's in red blood cells?
Iron.
What's in red blood cells? Hemoglobin. And what's in hemoglobin? Iron and what? Oxygen, right? Here's oxygen, okay? So B12 helps form red blood cells so that we can have this oxygenated blood that we need to live, right? Okay? So, it also helps with the central nervous system. Okay? So I want you thinking nervous system helps with red blood cells, right? Okay? Because when I have a patient with B12 deficiency, what kind of symptoms do you think they would have? They're going to have some mental status. They're going to have some neurological changes, right? Would you expect to see some neurological changes? Especially if they are severely deficient. The other part is, because of the red blood cells, would I expect to see some of those signs that we talked about, like anemias, like the hemoglobin, like the hemoglobin? Absolutely. Okay? So, we do not store B12. Okay? Your body does not automatically make B12. Don't know why we make everything else, but we do not. Okay? So, the only time you get B12 is when what? When you eat and ingest it. So, which population is the highest risk for deficiency? Vegetarians because they do not, you're vegans because they do not eat meat products or animal products, okay? So we have to kind of coax them along about that they may have to have some type of supplementation, okay? So, all things central nervous system involved, you don't have to memorize all these, but what I do want you to go is I do want you, what do you think that I want to make sure that you know of the most, that a B12 deficiency affects the central nervous system? Patients are going to be at risk for what? They're going to be at risk for falls, okay? Absolutely, all right? They have a stinging sensation of the tongue, so they may not, or impaired taste, they may not want to eat, so they may have some nutritional imbalances that go with that. The visual disturbances, that relates to falls. The numbness and tingling of their feet, same thing, relates to falls, okay? So these patients, it's more about safety, right? So you need to make sure you're understanding safety. You don't have to memorize all these, but I want you to be thinking B12 deficiency, neurological issues, make safety risk. Okay? All right. These other things just right here fall in line with that lack of that hemoglobin red blood cells. Like we talked about the glossitis earlier, they can have some anorexia and some weight loss. I do not care that you have to know all of these. Okay? I want to care that you know more how to take care of this patient. Okay, so the nutrition part of that, right? We talked about meats, right? Eggs have protein in them. You seafoods, right? So protein is that. Now, like I said, if they do not want to, if they don't eat like they're a vegan, they can have supplementation. So we can we get vitamin B12 over the counter? Yes. Absolutely. So they can go get vitamin B12 over the counter. Or they can also get vitamin B12 injections. All right, in the event that they're pretty severely deficient, and we can actually get a prescription where they give these themselves at home. So we don't have to teach them, just like insulin, how to give themselves an injection. Okay? I love vitamin B12. I actually give vitamin B12 to my horses intravenously. So, because if anybody been an athlete in high school, college, how does B12 help athletes? It helps provide energy, but it also repairs muscle damage, which is basically red blood cells. So if it repairs your red blood cells, it repairs and helps you recover muscularly. So that's why athletes love it, because they're able to recover quicker because you're putting such strain on the body. So that's why I want to give it to my horses every week, is because it helps them recover from their workouts so much better. So, do be mindful, that stuff will stain you. It is a red maroon color in that bottle, and if you get it on you, it will stain everything. Your clothes, your skin, all that stuff. Just so you know, it will stain you. So, okay. Folic acid. All right. Okay. Folic acid. Same thing. Here's the thing of why folic acid. So remember I had you put on there heme, and in your parentheses of iron, and your hemoglobin, and your parentheses of oxygen. This is where folic acid comes in. Okay. So folate, you can either call it folate or folic acid, they're pretty interchangeable, okay? Folate actually helps form heme, okay? So in that whole equation, you probably want to put up there where you put heme is iron plus, and then put somewhere in there that you've got folate forms the heme. Meaning that, do I have to have folate? Because if I don't have folate, do I have heme? No. So if I don't have folate, I don't have heme. If I don't have heme, that's my iron. I don't have hemoglobin. And if I don't have hemoglobin, I don't have what? Oxygen and acid. Okay? So they all go hand in hand together. Okay? All right. I don't really care that you know any of the rest of this except for that you knew that part. Okay? So same thing. These symptoms all kind of go together. We're talking about we're pale again, that we're tired, we're fatigued, we've got the tachycardia and the tachypnea, because that all relates to what? I can't, if I don't have folate, can I form heme? I can't form heme, I can't form hemoglobin, I don't have oxygen. That's how all these things relate together, okay? All right. So, supplementation, okay, we get folate. Folate comes in your foods. Well, it's got way too many clicker things on here. Okay, folate is food. We get folate from food. We get folic acid supplementation, like taking folic acid over the counter pills. Does that make sense? They're the same, but the only wording is that folate is the word for if we get it from our food, and folic acid is our word that if we're getting it from taking a supplement like pills. Okay. So folate in food is going to be in your green leafy vegetables, your fruits, your seafood, your beans. Okay. Are you guys tracking me here? So when you see nutrition questions related to anything, can you go wrong with meats? Can you go wrong with green leafy vegetables? Can you go wrong with fruits? Okay, I like it. Okay? All you gotta think of is does this sound healthy? Does this sound healthy? So there's an old, I had an old retired instructor, a faculty member. She kind of taught for me here, covered a couple of lectures for me here a couple of years ago, and she cracked me up because she was doing the hematology lecture, and when she wrote out some of her nutrition questions, 3 of the 4 answers had the word fried in it. And I said, fried, didn't matter. Fried chicken, fried pork chops, fried, and I'm like, what? I'm like, where's there? There's only one healthy option here. I'm like, we can't roll with that. I mean, like, because that's exactly right. You start looking as to what's the healthiest option. And to be honest, if you think about it, that's really how you can find your answer. What's the healthiest meal in this whole choice, right?
It's
Okay.
always the turkey sandwich.
Always a turkey sandwich. There you go. So that's exactly right. Or the tilapia fish, right? Tilapia and the turkey sandwich. That's what you're wrong with. All right. Now, if you're taking folic acid supplementation, you can get folic acid. We can do it in oral pills, or we can actually give it IV if we need to. Okay. Don't really care that you know about the dose. What I do know is that you tell your patients. Some patients, like your alcoholics, they may require higher doses. Okay, they may require much larger doses, and then those much larger doses will actually can turn that urine a darker yellow color. Okay, but same thing on there. The fall precautions is for all of these patients, especially if their gaining stability is affected. Okay, but really they can take folic acid and eat foods and folate and do this fine. Okay, what do you guys remember about polycythemia vera?
Red blood cells.
Okay, so let's talk about that. Poly means what?
A lot.
Many, a whole lot, okay? And anemia means what?
Blood.
Blood. So all polycythemia vera is that I got a whole lot of red blood cells, right? More than I need. I mean a whole lot more than I need. And what is that going to do? And when I have a whole lot of red blood cells, I now have a whole lot of platelets. Okay? Now, what is that combination going to do to my blood? It's going to make it thicker. It's going to make it syrupier. Okay? Now, think about that. If your blood was like honey thickness, would it flow real well?
No.
Would you be able to have the output of your cardiac output flowing through your vessels like you need to? So what's it going to do? It's going to slow down because it's thick and syrupy, right? What does that have a problem with? What can happen?
Clotting.
I can then have clotting, so now I got clotting issues, as well as is my output going to be as good? Is my organs going to get the blood it needs? No. So these symptoms that you see are going to be related to some of that. That shortness of breath, that dyspnea laying down, okay, that dizziness. My organs are not getting the blood it needs because this stuff is moving at a syrupy pace, right? It's not moving quick enough because it's so thick. What's the solution? Huh? What's the solution? IV fluids is your solution. Why is IV fluids, and I mean aggressive IV fluid therapy, why is that my solution? Because what am I going to do? I'm going to kind of dilute it down and make it not as thick. So I'm about to thin it down a little bit, right? I'm about to thin it down a little bit by giving IV fluids. So not only is that going to kind of thin it down, is that going to help the blood flow better? Yes, it's going to help it flow better. So these patients are going to need aggressive IV fluid therapy, okay? The other thing is they need to not have tight restrictive clothing. They're already having issues as it is, right? This blood isn't already flowing great as it is, so we don't need tight clothing on to cause further restriction on there. okay? As well as extreme temperatures, more so the cold. What happens when you're in the cold? It causes constriction. I don't need anything that's gonna cause the blood to slow down even more than it's already moving, okay? All right, that's the key piece on that. Okay. All right, let's talk sickle cell, all right? Sickle cell sounds a little intimidating, right? It's really not, okay? When we make every 120 days, we will produce these new red blood cells, okay, that are carrying that hemoglobin, that's carrying that oxygen to our organs. It goes through our major vessels, right? So it comes out of the heart, right? Through the what? Comes out of the heart through the what? Through the aorta, goes all the way down the aorta and it splits, and then it goes off into some other medium-sized vessels, because remember, our aorta is the largest vessel in the body. It goes into some medium-sized vessels, and then those medium-sized vessels then turn into tiny blood vessels known as what? Capillaries. That's like at the tail end. So when you think capillaries, you think of like, here I've got vessels, right? I got arteries, I got veins, but when I get down here, do I have any of that in my fingers? Or my toes or anything like that? No. So it's going to fade it into some capillaries. That's the smallest blood vessels that you have in the body, okay? Now, what normally happens is the way that our red blood cells are designed is that our normal red blood cells can squeeze through there. It can squeeze through, it can go through the large blood vessel to the medium size, down to the tiny blood vessels, which is the capillaries, right? That's how our whole body gets its oxygenated blood. When you have a patient that has sickle cell disease and they start the sickling process, okay, what happens is those red blood cells now become longer than normal and they become stiff. So they're long and stiff and they're not small, shorter and flexible. So what do you think happens when it gets down to the capillaries? They get stuck. They get stuck. That's what causes all that pain that they feel. Because you got these things that are stuck down there, right? Okay? Now the problem is also because of how these things are shaped, these sickling cells are shaped, they can't really carry the oxygen that they need. So not only do they get stuck, they're not carrying the oxygen I need. So is my body, my organs getting the oxygen it needs? No, it's not. No, it's not. Okay? And what's going to happen is, when they get down there, because they're real fragile now, these things, remember, they're long and they're stiff and they kind of get down those capillaries and get stuck. What happens is they break apart. What is that called when your red blood cells break apart? It's called hemolysis, right? Okay? Now let's think about that. Okay, so what's inside the red blood cell? Hemoglobin. And when hemoglobin breaks apart the red blood cell, what does that make? No, come on, what's that make when it breaks up? Bilirubin. Absolutely. Absolutely. So you're going to see that increase in bilirubin levels because of this hemolysis, right? So what's going to happen? How do I know I got all this bilirubin levels high? Jaundice, right? So the sclera is going to be yellow, the skin's going to be yellow. Then they get mad because they're all itchy, right? That bilirubin makes them all itchy, okay? Now, what's going to happen is I get down there in these capillary beds and now I get these thrombi, okay? Now, so I got all this kind of clotting going on. Then guess what? What does the spleen do? What does the spleen do? It filters the blood, right? The spleen helps filter the blood. So now, if I'm already got this jacked up blood anyways, right, okay, is my spleen going to be able to filter like it needs to? No, so it's going to start getting enlarged and congested. And they can have that pain in that splenic area as well. Okay? So that's what causes this whole problem. Okay? Now, sickle cell crisis, they can come and go. They can be intermittent. A lot of times patients know what brings it on. Okay? But there are some things that we have found that really can cause this. Okay? So such as your patient being dehydrated. What would cause your patient to be dehydrated? What would be some things of why your patient is dehydrated? Maybe it's summertime and they've been out working in the yard all day. It's 100 degrees out there, right? They've been out there 6 hours mowing the yard. Is that going to cause dehydration? Yes. Maybe they had a virus. They've been vomiting, diarrhea. Is that going to cause dehydration? Yes. What about infection with fever? Yes. Okay. These things can cause them to go into a crisis. Okay. Cold temperatures. They cannot tolerate cold temperatures. They cannot live in Minnesota. I'm just gonna tell you right now, okay? They cannot live in Minnesota. They cannot do high altitudes. They cannot go to a ski resort for Christmas. Not gonna happen. It's gonna put them in a crisis, okay? Infections is really the #1 reason that puts them in a crisis. So what would we do? How would we avoid a crisis? We gotta teach them, hey, you're gonna have to make sure that you're drinking plenty of fluids, that you don't get dehydrated. You can't be living in Minnesota, okay, or going to Colorado on ski trips. You can't be flying in all these airplanes. And we have to prevent infections. How would we prevent infection? How does your patient protect themselves from infection?
Hand hygiene.
Huh? Things like maybe they wear a mask when they're in public, that they limit the visitors they're around, right? Okay, what about staying up to date on their annual vaccines, right? Their pneumococcal vaccine, their flu vaccine, right? Okay, good hand washing, all right? All things to prevent infection is what they have to know about, because that's actually the #1 reason that winds up landing them in there in a crisis, okay? Okay, so some things, right? They're gonna be tired and pale because what do we have a problem with? We have a problem with these red blood cells and that hemoglobin, right? Okay, so not oxygenating, that shortness of breath is gonna come into play. They have a lot of pain in their joints. Okay, anywhere that a place where this blood can settle in and kind of form thrombi, especially like in their joints, their hands and their feet, they're gonna have a lot of stuff. I tell you right now, it is really hard to manage pain in a sickle cell patient. I've never given a patient more pain medicine in my life than I have sickle cell patients. It's very, very difficult to manage their pain, okay? Then they also, huge risk because of the clotting, what are they at risk for? They're at risk for strokes, they're at risk for pulmonary embolisms, for PEs, right? They're at risk for myocardial infarctions, they're at risk for DVTs, all those things, right? Anything that forms a clot, they're at risk for, okay? All right.
Is this genetic?
Yes. Yes, it's genetic. And I don't remember all the genetic traits, but I feel like it skips a generation. I feel like in my brain, I remember that it skips a generation. So like if you have, grandma has it, her daughter may not have it, but then the granddaughter will. I feel like it skips a generation. Yes?
That depends to mom and dad are both carriers.
100%. You're 100% on that too.
Can't you be a carrier but not have
Yes.
actual, but
Correct.
can't have actual sickle cell?
She doesn't have the sickle cell anemia, but she has the trait.
The trait of it. And that's where a lot of times, so basically, let's say that you got a couple that want to have a child and one of them has had sickle cell. Usually the other one will have some genetic testing done because basically what they're carrying the trait. They're gonna have genetic testing done because generally when it skips a generation, they're gonna have to then consider on, is this something we wanna do if we're both these carriers and then it's likely that our child's gonna have the sickle cell. Yes?
I know it's their bodies making the sickle cells, but could they try like blood transfusion to calm it down?
Okay, fantastic point. So here's the thing. We do blood transfusions on sickle cell patients when their hemoglobin is way lower than normal. Usually we won't transfuse these patients till they're 6 or less, okay, because of the risk of the reaction. However, the fine folks over in Europe, okay, who have made some great strides in this with their medical treatment, have actually done now where they basically, I can't remember what it's called, but basically your body gets a whole entire oil change, okay? So since we know that red blood cells reproduce every 120 days, they have these patients come in before then, and they basically take a whole body's worth of donor blood, and they cycle out their blood, and they basically do an oil change, and they will replace it completely with donor blood. Yes. Yes. About every 100 days, they do it again, because they know at 120 days. And what they have found is that the likelihood of them going into a crisis has drastically decreased to a minimum, and they live longer.
So
They live longer because you're preserving their organs better.
So they say that you can die from the sickle cell crisis, is that basically just like the
It depends on, the biggest thing a lot of times that happens with these sickle cell patients is the damage to their organs over time. Over and over and over the damage to the organs with that. So it's usually more of a chronic thing. Yes?
Where's the increase in clotting come from?
Okay, so remember, we talked about on there, when these red blood cells, right, they're longer, okay, they're longer and they're stiff. And when they get into the capillaries, they're not flexible to flow through the capillaries, so if they can't flow through the capillaries, what are they gonna do? They're gonna get stuck, and they get stuck and they clot.
But it's not the platelet do, it's just the vasoocclusion?
Correct, correct,
Okay.
yes, yeah, you're correct. And there are many different types of crises that they have that varies as different types, there's like 4 different types, but I don't care if you need to know all those, because it doesn't matter, the treatment's the same. Okay, the treatment's the same, but they can have different types of crises that come in play there, okay? Okay,
It's actually good to have the trait, the sickle cell trait, right?
but versus having the actual disease?
No, the sickle cell trait is beneficial because you can't catch malaria.
I didn't know that. I didn't know that.
And so that's why it's very
I don't know, I mean, I've been thinking, what's the odds of malaria versus, I'm traveling to third world countries, maybe?
That's why it's from equatorial areas, mostly population from equatorial
Yeah,
areas.
because it was a protective
Because it
mechanism like
protected them,
forever ago.
right?
Really?
So
I did not know that.
you got sickle cell bad luck, but everybody else was just doesn't.
Really? Okay, so, all right, so hang on, guys, so I am intrigued, hang on, 'cause this, hang on, no, hey. Now I'm intrigued, because then this would have been what historical area did this, area did this come from?
India, Africa, African
What,
Americans.
what
right?
historical age, what time frame in time, when did this happen?
When did they find out, or
Like,
when did
when
sickle
was-
cell come about?
When
Yes,
was
that's right.
malaria
With the rise of malaria and mosquitoes. Yeah.
Which would in what time frame though? I gotta think, like 1800s, 1600s, we're talking 1200?
Probably 50, 100,000 years ago.
That's what I'm saying, I'm just kinda trying to figure out like where, cause like it's
And they
like,
Northern Europeans lost it because there's not malaria carrying mosquitoes up there.
right? So, interesting, well, see, and that's the thing, cause like the biggest treatment that they're being aggressive with right now is in Europe. Like they have a lot, and I think the reason being is that Europe's being aggressive with that is because they're they're being more, they're trying to find more holistic type preventive, because they're like, it used to be where sickle cell patients wouldn't live past their 20s.
Well, they're also trying to make up for colonialism a little bit over there.
True.
It was
But-
70,000 to 100,000.
But yes, but these patients used to not even live past their 20s, just like cystic fibrosis patients. They used to be dead by the time they were 20. I took care of some cystic fibrosis patients that if they lived to be mid-20s, it was a miracle. And so the Europeans over there are kind of experimenting with some of that of how, and that's what this was a lot of it is to prolong life and a lot of prevention type stuff. Now, I can't imagine what it would cost. I can't imagine what it would cost to come in for a complete oil change over 100 days. And in fact, you gotta have the donor blood to do it with, right? So I don't know if they're just rationing theirs a little better than us over here or what, but I did find that to be very interesting over there.
So, since pain is one of the things that we're treating the most with, and we already get like opioid pain medicine, on top of like, they're not having oxygen, so their organs are being damaged, that not contraindicated?
Well, here's the thing, okay, so here's the thing about that, you do have to think, so let's think about that, so you're kind of correct on that. They can have some liver and kidney involvement. What does that tell me if I got a patient that their liver is not functioning as well, or their kidney is not clearing it as well? What does that tell me on how I may treat a patient with pain medication? What do I think of? Am I gonna have a delayed metabolism response? Yes. So does that mean I might get the effect I need immediately? No, it might be a little bit later, but then that also means that I have to monitor that patient closer, because I may go, yeah, this normally kicks in about 30 minutes, but for them it may happen in 2 hours, right? Okay? So you always, in any type of patient that has a liver issue or a kidney issue, a liver issue, especially with the metabolism part, you have to always watch them for delayed response. Okay? Because you go, oh, well, 30 minutes, they seem like they're breathing okay, everything seems to be fine, and then 2 hours later, the patient's not breathing. Does that make sense? Because there's a delay in that metabolism response. So, very good point. Some other things that you might see, we already talked about the jaundice, but that occlusion, they'll have a lot of swelling in their hands and feet. We don't ever, even for the swelling of these patients, put anything cold. So we don't do ice packs for these patients. We do not do the ice packs. It's really hard to get them comfortable and deal with these painful issues like that. We can elevate them and we can even compress them, but we don't want to put any kind of hold on them. Okay?
Dr. Glenn,
Yes.
And the sickle cell crisis, could they be at risk for a seizure?
I don't know, I think like, I would say no, because really the only major neurological issue would be if they had a stroke. Now, let's think about that. If they had a stroke, then could they have a seizure? Yes, so it had to be a complication related to something else. Okay, alright, so oxygen. Oxygen therapy is important, right, because of this hypoxia. So like I said, we don't have this hemoglobin flowing like we need it to because of these red blood cell issues. So oxygen is a priority. IV fluids, okay, we need to treat these patients aggressively with IV fluids, right, okay, because we want to help that blood flow. We don't want it getting stuck, right, because it's already stuck and occlusive. We want to help it flowing, okay, so we're going to give them IV fluids to kind of help reduce that thickness of that blood and keep it flowing, okay? It'll also help preserve your kidneys that way, and pain medication. Opioids is your primary choice. Things like what? What's some opioids? Morphine. IV morphine, IV hydromorphone, IV fentanyl, things like that. A lot of times these patients are on PCA pumps. I've had several sickle cell patients that come in that the best way to treat them is with a PCA pump. Let them push that button every 8 minutes and roll with it, okay? And I've even had them before where they had to be on a continuous PCA infusion, and then they click the button every 8 minutes to give them more, okay? Because they require such high doses, way higher doses, okay? So, all right, antibiotics, especially if they're in there for an infection, okay? Blood transfusions, we really try to hold off on these. They really do not want to give them unless that hemoglobin is under 6, because we're trying to reduce the amount of time of reaction. Yes?
So we're treating them and we're giving the IV fluids and all this. How long are we having this sickle cell crisis? Is
It varies.
a couple days?
It varies.
Maybe a month?
I've had, well, that doesn't generally last that long. I've had them come in sickle cell crisis and we can get them over it in a couple of days, and sometimes I've had it where it goes on to a week. It just, you're trying to aggressively get them through this. But the body itself, you can't demand the body and put a timeline on that.
Do they become more frequent along their later days?
Yes, as they become more organ failure, as they start to have more long-term organ damage, you're gonna see them more frequently. And it really isn't necessarily because of crisis as much as it is the organ failure problems. They may eventually wind up on dialysis, they may eventually wind up with some type of liver failure, they got ascites, they can have a lot of things, yes.
With all the opioids, and how do they not be like respiratory?
Okay, very good. Number one, because they get it so much, what happens? They develop a tolerance to that, but does that stop, does that release me of my responsibility of monitoring this? So same thing, you always are gonna monitor respiratory status in any patient that you're giving opioids to. But because they built up a tolerance to that, I won't say that it wasn't happening, but you can't go, my God, they want me to go give them 10 milligrams of morphine and this that we are used to giving 2. You know that they're gonna take higher doses, but you're cautious. You go, okay, I'm gonna make sure. Same thing, that's why the PCA pumps are really great. Because remember how I talked to you guys about that CO2 device that goes, the nasal cannula CO2 device? That thing will tell me when those CO2 levels are up and I can go in there and see what's going on. So, but you still have to monitor for respiratory pressure. That's still my number one concern with anybody that gets opioids. So, yes?
So how come they're worried about the antibiotics causing hearts and
Well, but you gotta think about it, that's in limited places. We're not doing it over here. So we have to be thinking about, we are still rolling with blood transfusions when they need it at a certain level. And like I said, they're very, when I mean very cautious, I mean, there's been times where I'm like, well, man, we really kind of brought on hold it and the docs try to hold off as long as they can. But I don't foresee us following suit with Europe because I don't think we can keep up with the demand. Like over here, I don't think we could keep up with the demand of the sickle cell population. Yeah, I just don't, if you saw everybody that had sickle cell come in every 100 days and we're gonna get an oil change, we don't have enough blood now to roll with what we got. You see what I'm saying? I don't think it is.
might not supply blood? I was thinking it was because they developed antibodies, but that's not.
Well, and it also kind of depends, because we screen for antibodies when we give blood, but you're also talking about, you're increasing a much higher risk. There's a lot that goes into the screen before those patients come in for their complete transfusion to make sure that they're not gonna have a reaction. Could you imagine what would happen if you gave them that and they had a reaction to it? You'd kill them. you know, so I just don't think, I don't ever foresee us here in America being to that point. So, okay, all right, that's all we're gonna really take care of there. Did y'all learn anything about the hydroxyurea? Huh? You did learn about the hydroxyurea, and it's really a cancer medication on there, but the hydroxyurea can actually cause thrombocytopenia, and we're gonna talk about that in a little bit, and it can actually cause, more neutropenic type of issues, so we'll talk about that in a little bit as well. So, okay, so we talked about oxygen, we talked about IV fluids, we talked about pain medicine, we talked about blood transfusion. If they have fever, we can go with some Tylenol or some acetaminophen, as long as there's not what kind of problems?
Liver.
There you go, as long as we don't see any issues with those liver enzymes in those liver, okay, we're good with that, okay? All right, I'm trying to think of some of these other things. You already know about incentive spirometry, we do that with every patient that's in that hospital. And you know about DVT prophylaxis, because that is on every patient, but it's especially for them because they've already got clotting issues, right? They're already at high risk because they've got clotting issues, you know about that, so. All right, infection, we've already talked about all these things, about preventing infection. With them, we've covered immunizations, flu and pneumococcal, we've talked about all those things. Okay. I'm just trying to see if there's anything else I need to hit on here. We've talked about all of those things there. Oh, decongestants. They definitely don't need to take any decongestants such as what? What's a decongestant? Like Sudafed, which is pseudoephedrine, right? Because why was that? What's Sudafed do? What does pseudoephedrine do? It causes what? Vasoconstriction. It causes vasoconstriction. Do we need them to constrict down the blood vessels? No, we already got blood flow problems. We don't need to add to it. Okay, so they need to avoid decongestants. Okay? All right, let's do this. Let's take a quick test. Unless I'm watching a trend. Okay, and what I mean by that is, if your patient had a platelet count of 120,000 today, and tomorrow it went down to 80,000, and the next day it went down to 60. Am I at 50 yet? No. But do I have a significant trend? Yes. In 2 days I went from 120 to 60. Am I concerned? Yes. So even though I'm not at that magic 50 number yet, I've got enough of a trend to support that I've got concern for potential hemorrhaging, right? Okay? Because what do platelets do? Platelets are the glue, right? They're a little sticky piece and within that blood that kind of helps with clot formation, right? Okay? So we have to have that. And if we don't have that many, then that now means we're at risk for hemorrhaging just because we don't have the clotting factors in there, right? So you're going to see some things like this. You're going to see where you may have bloody urine. You may have nosebleeds. You may see significant bruising. What's this called? Okay, just making sure that's not a rash, okay? There's not that kind of, because I did have a question with the picture. That people, I thought that thing was a rash. Fair enough. That is the C, yeah. They may have bleeding in the gums. They can have black tarry stools from a GI bleed, okay? All things that may suggest bleeding. I've actually seen patients with such low platelet counts, they just start oozing out blood. And it's actually what they go into what's called DIC, okay? So, all right, so all things blood related, right? Okay. All right, they start just oozing out of places, okay? They may be tachycardic, especially if they're hemorrhaging, because what's the body trying to do? Compensate. My blood pressure drops out because I don't have any circulating blood volume, and they get into that respiratory distress, okay? So what's the treatment?
Platelets.
How do we fix this? Platelets. We can do platelets. And remember, platelets, plasma, red blood cells, factor blood cells, that's all part of your blood product. So even giving platelets, we follow a blood transfusion protocol, okay? All right, so the key piece is that we have to try to minimize them bleeding, right? We don't want them bleeding to death because then they cut themselves with a knife, okay? So we want to stay away from rectal temperatures, enemas, and suppositories. Why? What do we not want to do? We don't want to do anything that's going to tear the rectal lining because they'll start bleeding, right? Because the rectum is tissue. If we tear the rectal lining, they can start bleeding, okay? Keeping the room free of clutter because we don't want them to fall. These patients fall and trip over things, so fall precautions is definitely a necessity. If they fall and they hit their head, they will develop a head bleed, okay? We don't want to do that, all right? When assessing blood pressure, very difficult that we don't want to assess blood pressure on them as frequently But what's the best way to take blood pressure for this? What do you think the best way to take their blood pressure is? Why manually?
You can control
Because I can control it. What's the thing you hate the most about the automated thing? It takes forever, it keeps pumping up slowly, it's squeezing, and by then my hand is numb and tingling. A manual you control so you can decrease the risk of all that pressure causing some issues with that, okay? Minimizing blood draws. We don't want to just keep poking them, okay? We don't want to just keep drawing blood. We don't want to keep just trying to start many attempts of IVs. We want to try to avoid Foley catheters or urinary catheters. We want to not, if we don't have to put an NG2 down, anything that we can prevent having to do to these people that may cause them to bleed or poke holes in them, we want to do, okay? Bleeding precautions. We're going to talk about that in a minute. In the event that they do have a laceration or that you do draw blood or you do start an IV or take one out, you're gonna have to hold direct pressure for a lot longer because they don't have that clotting piece in there that they need, okay? We don't wanna do intramuscular injections because what's one thing that's required with an intramuscular injection? Takes a bigger needle, which does what? Pokes a bigger hole, okay? Which then increases their risk of bleeding from that, okay? All right, let's go through bleeding precautions real quick. You guys know most of all this. Soft bristle toothbrush, right? No flossing, okay? If they want to do anything, they can actually use some cotton balls or something along that line if they're trying to kind of get around those areas, but they cannot be doing flossing, okay? Electric razor, all right? We talked about shoes or the non-slip socks. All right, we want to decrease risk of falling. Stool softeners. We don't want them to get constipated because what do you do when you're constipated? You start straining and bearing down and you'll start tearing things in that rectal or that lower colon, and we don't want to cause a GI bleed from that. So stool softeners, nothing in the rectum on there. We don't want them blowing their nose because what happens when you blow your nose? Use pressure. Yes.
Okay, so the no flossing, can they use like a water pick?
Water pick is different because you're not actually doing anything to it. Like you're not causing any kind of trauma. You ever done that before, like when you floss and like now like little handheld ones, you know? But you actually push down in there and you're putting pressure and then when you pull up you make your gums bleed.
Yeah.
A water pick is like a least invasive way because you're using water as the pressure. So you could probably use a water pick. That would probably be okay. Really? And they were alive.
The only reason she got stayed down there is because she had a finger bender and she instantly bruised with the seatbelt. And they rushed her to the clinic.
I feel like some form of cancer had to play with that.
They had no idea what it was. They took her, all her medication off, but it was there for a whole month.
I had a feeling she probably, that was crazy. Felt like she needed to roll down to like some
We
Johns
couldn't-
Hopkins or Mayo Clinic or
I couldn't keep
somewhere.
somewhere to. There was only one
Yes.
person.
That's crazy, yes.
Okay, so like we're talking about the flossing, so as far as like when they need dental procedures,
They don't get them.
They don't get them.
They don't get them. And the reason being is, dental emergencies are kind of very rare, right? So you have to outweigh the risk versus the benefit. Would you want to have your wisdom teeth extracted out? No. No. Would you want them cutting in for a crown? No. So what I'm saying is, it would have to be a true emergency.
okay.
But, what's the fix to this? We get platelets. So what we can do is if somebody's got a disorder that's causing this, we can infuse platelets to get it up there where they can't have a procedure. It just can't be like right away. We have to make sure that they're scheduled to do that. Yes.
So I know that this is like normally a side effect from something. How quickly does it resolve? Like, is it after you take one bag of platelets and they're pretty much?
Aha! Okay, so what do you think? You think this can be based on the patient? Yes. 100%. So what we do, we would give them some platelets. Are we gonna do a blood draw immediately? No. A lot of times the order's gonna say repeat it in 4 hours. Because one, that allow my body time to catch up where I'm gonna get a better accurate lab result? Yes. We're gonna recheck them again. And let's say we made a little bit of progress and then maybe have you give them some more. We've made a lot of progress, we're gonna wait. We do the same thing with blood. We may transfuse, it may say transfuse 1 unit, hold the other, do a blood draw in 4 hours after the blood's finished. If it's still less than this, give the next one. Because every patient responds differently.
But they shouldn't be like thrombocytopenia for like 5 days.
Depends on what the issue is. Like some of your cancer patients, your significant cancer patients, good. Yes.
So on our previous lecture, we called it an X-linked genetic disorder, and we did a little Punnett square, and like, so it's 50-50 that a son will have it, and 50% a daughter will be a carrier. So when you also talk about an
Thrombocytopenia is not a disease. It's a condition.
So we don't need to.
It's a condition caused by something.
It is not, thrombocytopenia is a condition, and what do I mean by that? So let me tell you this, okay? All it is, what's thrombocytopenia? Let's not make this complicated. What is thrombocytopenia? Low platelet count. Can somebody have a low platelet count for one reason, and then you have a low platelet count for a different reason, and then you have a low platelet count for a different reason? 100%. Does that mean that you have it for forever? No. When I correct the problem, does that take care of it? Or if it's being caused from something like your cancer patients, right, that may be thrombocytopenic, when the cancer is resolved and I'm done going through all this chemo and crap, am I always going to have thrombocytopenia? No, I can resolve it. So it is a condition.
Dr. Glenn.
Yes.
Maybe talking about hemophilia is the,
Okay, now here's the thing. That's completely different. Hemophilia is completely different. Okay? But here's the thing. You are going to worry about hemophilia, as you know when? In pediatrics. Not my.
I was just saying, John.
That's what I think, yes, that is what he is referring to is hemophilia. Hemophilia A, you're gonna learn about all that in pediatrics. And the problem is it's not thrombocytopenia with hemophilia. Hemophilia has to do with factor VIII. Okay, that's the genetic set.
Okay, that's.
Yes, I am trying to learn this.
Okay, so platelets.
I can't cover all this, huh?
Like platelets is a primary like resolution, but can you do like vitamin K, or that don't matter because it's so low?
Okay, so vitamin K is going to fix my clotting factor.
But not the platelets.
Correct. Yes, correct. Okay, but very good point that you make, because my clotting factors, such as vitamin K, okay, what other piece of my blood also is going to help with that? Not my packed red blood cells, not my platelets, my plasma. Yeah, so if you got a high INR, remember how we talked in cardiac about warfarin, right? And how that INR, we got to monitor that, and how that INR can be off the chart. It decreases the viscosity of blood that way, where basically it's the clotting factors that's the problem. So that's why vitamin K or your fresh frozen plasma comes into play with that. Platelets, you gotta have platelets. You gotta have all three. You gotta have red blood cells, you gotta have platelets, you gotta have plasma. But yes, what John is talking about, that you guys learned about hemophilia, that's a pediatric issue. It does have these same bleeding precautions, but thrombocytopenia itself is a condition. Okay? All right, no blowing in the nose. We don't want to use a knife. Okay? When we use a knife, it's got to be sharp. Why would you want a sharp knife and not a dull? If I take a sharp knife, it's going to slice through what I'm trying to do with ease, and we're going to move on, right? Anybody ever had a dull knife and you're sitting there doing this? You are more likely to hurt yourself trying to put pressure and trying to cut something with a dull knife than you are if you've got a really sharp knife, okay? And then, of course, it's going to take a lot longer for any type of laceration or puncture, okay? So we want to keep those to a minimum. Okay, let's talk blood products real quick. Okay, let's go to blood products real quick. All right, that's what a bag of packed red blood cells looks like. All right, you guys learned about blood transfusion? Yes. Fantastic, okay? All right, so equipment I don't really care about, but you know that this is what it's going to look like. You got your bag of blood. It's going to come with a Y connector kit. So you got this Y connector. This is blood tubing only. Nothing goes through this but blood and normal saline, okay? Your sodium chloride, okay? And then you're going to have a bag of sodium chloride, your normal saline up here. And that's how you're going to prime this line with your saline first, all the way to your patient. And then you'll close this clamp and you'll open up your blood. And what I normally do is I already have everything ready to go. I don't ever start this until I've done all my checkoffs. Okay? Now here's the thing. So who can go down to the blood bank and get the blood? Anybody. Anybody. You can send the IA down there. You can send the maintenance man if you want. Anybody. They just have to have the slip to go down there and get it, so they know what they're getting, that the blood bank's going to give them the right one. Okay? Then when they come back up, okay, then the nurse gets the blood. What does the nurse need to do?
Get another nurse.
Get another nurse. Can it be an LPN? Yes. It can? Yes. One.
They're just
Any two licensed nurses, right? So it could be the LPN because they're licensed. It could be another RN on the floor. It could be the charge nurse. Why would it be the charge nurse? Because who's the charge nurse? An RN. Your charge nurse is an RN on the floor, right? Okay? So it has to be like any two licensed nurses can verify this blood. And what you're checking is, you're checking all these things. You're gonna check that the blood type and the RH is exactly what the patient has, the blood unit numbers match what's on the slip, the expiration date is good. You're gonna go through this whole process at the bedside. At the bedside. Okay? All right. Very important to know that you want to hang it within 30 minutes of getting it from the blood bank. You don't just sit on the counter and walk off and leave it for 2 hours. This blood has to be infused within 4 hours. Most of the time, we can infuse a unit of blood within 2 hours. Okay? Who do you think might take 4?
Elderly?
Okay, I like where you're going with this.
Sickle cell?
Elderly that has what?
Small veins.
No,
Or
not small
allergy?
veins. Come on, who do you think? Who's my risk for fluid overload? My cardiac patients. Why would I infuse this slowly? So that they tolerate it and they don't quickly get fluid overload. Okay? So those kinds of patients are going to generally make it go over 4 hours. I used to have docs that would tell me infuse 1 unit over 4 hours, give 40 milligrams of IV furosemide and infuse the next. Why are they trying to do it? They're trying to prevent fluid overload. They're going to have me go ahead and pull some fluid off after the first unit before I turn around and give them the second. Because is it the volume I need? No, it's what's in the blood component that I need. Okay? So it can't sit for more than 4 hours. We can't just leave it hanging around. Blood tubing gets changed after each unit. Okay, blood tubing. Why do you think that would be important to change it after each unit?
Clotting.
Why could I not just throw 1 unit into trash, go and get the other unit and hook it up and then start doing it? Because they're different people, they're different blood, right? And if I have a reaction, I don't know if I created that little situation in the tubing because I'm mixing blood together, or if it was the patient in the blood or whatever happened. So we always going to change the blood tubing. I mean, it's a simple little Y connected thing, very easy to do, right? Okay, and there is a little video, I did leave some little videos, so I probably will kind of just post this for you guys because there's some little videos in there that you guys are really good. Okay, all right. So we're going to get ready to start this blood, right? We take vital signs before, and then when do we take them again? At 15 minutes. What do we do during that 15 minutes? We stay at the bedside with the patient, because what am I looking for? Looking for signs of a reaction, okay? And then after we've gone 15 minutes times 2, then we can go to every hour, and then we take post-transfusion. There's actually, you need to document this, because then when you actually go into Epic, you have to document these timestamps. So it's a lot easier just to do it at the bedside, right? A whole lot easier just to do it at the bedside. Can you start the blood and then ask the PCT to stay with the patient?
No.
No. Absolutely, do not leave that patient, okay? Never put any medications with the blood, so we never give any medications in the IV with the blood. I about had a stroke one time because I saw a nurse in one of the ICU units was trying to figure out how to troubleshoot because they were getting blood and all the IV lines were taken up and they needed to get some meds. And they're like, well, I'll just give it with this blood. And I'm thinking, oh, God, help me. I'm like, I'll put you in another line. I'll put you in an IV if you need. Please don't be mixing medications with that blood. Okay? So, all right. Always going to flush that tubing behind. So, and before you discard the tubing, because there's still blood in there and they need that blood part. Now, let me ask you this. What do you do with the blood bag and the tubing afterwards? Goes in a biohazard bag. When do you not throw the blood in the biohazard bag? When there's a reaction, because where does it go? Going back to the lab. So if your patient is having complications like a reaction, we don't throw that thing in the trash. It's got to go down to the lab, and we actually got to file a report because the lab is going to have to go back and check and see did we miss anything in the process that they went through to make sure that this patient wouldn't have a reaction. So we always do that. Okay? Always document the date and the time, and then how long it took to transfuse and how much was transfused. Okay. Awesome. Another thing, let me ask you this, okay? What? Can blood go through any IV?
No.
Ooh. What can blood go through? Okay, so, worst case scenario. Worst case, blood can go through 20. Blood can go through 20 if it has to. I don't like the idea of it, but it can. Anything smaller than a 20, like a 22 or 24, that's an absolute no can do. Okay? So if you've got a patient that has, and it's got an order for blood, and it's an elderly frail patient, and you notice that all they have was a 22 gauge in there, what are you going to do? I'm gonna have to find another vein that's bigger, that at least if I can squeeze a 20, 18 is preferred, right? Okay, don't get happy with the 16s, people, okay? Patients don't like the 16s. 16s are safe for trauma patients, okay? And if you've ever saw the size of a 14, you're gonna be like, oh yeah, I actually used to just stab people in the chest with 14s. So it's called needle pressure. No, I don't enjoy stabbing people with a 14 gauge needle in the chest because they're dying on me. That's why. That's the only reason I'm stabbing them in the chest is because they're dying on me, and that's a little stressful. I don't know about you, but it's a little stressful, okay? So no, the very first time I ever did a pericardiocentesis on the scene, I thought I was going to pass out. I had no choice. I had no choice. And I got a green spinal needle and hooked it on to a 30cc mil syringe. And I asked my partner, and I said, man, I think this patient is in tamponade. He hit the steering wheel, his head-on accident. And I think this dude's cardiac tamponade. That's what our problem is. He's like, all right, well, make it happen. And I'm thinking, oh my God. I looked at the needle. I'm like, I'm about to stab this in this man's heart. I was like, yeah, it'll make you kind of tighten up a little bit. I bet you're going, I'm not sure what's going to happen right now, right? But yes.
The question I have is not, I don't think you were gonna ask about on the test, but it's just the general.
You don't know what I'm going to do.
Oh, okay, well, in theory, okay.
It does vary.
In theory, like, okay, as far as prioritization when it comes to these patients who need blood transfusion, and you've gotta spend a lot of time in the room doing all the checks and stuff, like, how do we prioritize them versus our other patients? Like, to make sure they get proper care and things.
Okay, so here's the thing. What do you think? So let's say this. Let's say that you had a sickle cell patient. Okay, so let's say that you had a sickle cell patient that has a hemoglobin of 7, but your docs decided to go ahead and give it. Okay? But then, let's say over here that you had a thrombocytopenic patient, but like you said, and maybe they've got to go to the OR for a GI bleed, and you've got to get some platelets in them pretty quickly. Who would you see first? Platelets. Why? They could die real quickly from that, right? And I've got to get them ready to go to the OR. But why not my sickle cell, the hemoglobin 7? They didn't get that way today, right? And I'm probably not going to fix them after that either, right? So you see what I'm saying? You've got to look at what's in front of you. What can I make the most difference with, and who might die on me right now? Okay? Who might die on me right now? Okay? So just like on the GI, there's a couple of those that you guys got the first and the last. Right? Fair enough. The middle pieces got you. But let's think about that. Okay, so the two middle pieces is you had a patient that had a colostomy bag that was 1/3 full. Is there such a thing as an emergency to empty a colostomy bag? No. Did it say it was laying on the floor? No. Did it say that the ostomy was exposed? No. There's no such thing as an emergency to empty the bag. But the other patient was a bowel resection wanting pain medication. So are either one of them going to die on it? No. But what I need to put comfort over a task. Emptying a colostomy bag is a task.
Okay, well, you need to look at mine, because I had it in that order.
No, you didn't. I looked at it. No, you didn't. I've had many of you say look at it, and every one of them I've looked at. No, you didn't. The one that you're talking about, there is one that you're talking about. However, same thing. You got the top one and the bottom one, but where you
I'm
got
glad you
those
explained
other
it to me
two
because it's a
reversed,
cute,
you picked the
but I
patient
still,
pain second,
they
and
say,
you picked the patient that
nobody
has
ever,
CT oral contrast third.
that's
Ring a
frustrating.
bell? Yeah, now, let's talk about, now let's talk about this. Why do you think a patient that has CT oral contrast ordered would be priority over good pain management?
Because
It's time sensitive. I can't go in there and drop this cup off and go, okay, drink this when you get a chance. By chance, when you get done, just let me know and I'll come back, right? No. And then I come back an hour later and they drank half of it. Have I already messed that whole thing up? Yeah. I've already messed that whole thing up, right? Says it's time sensitive. So I know that I'm gonna have to go in there, I'm gonna have to get this patient to drink this, or I can delegate that to a PCT, and I go, well, you go in there and you get Mr. Smith to drink that, you just keep handing him that straw, keep having him sip it, and don't let him stop, and when he's done, let me know, okay? Does that make sense?
Yes.
It's time sensitive, okay? Those are challenging questions, but it's getting you to think, who would I see and when, and why? Didn't say delegate, did it? Didn't say delegate.
No.
It said, who are you? You're gonna learn about some delegation all you want next semester. Yes.
So what was the full order?
Hang on, let me hear what he's got to say.
What was the full order? So pain.
I got another issue over here I gotta go deal with. You see what I'm saying? It's prioritization. It's all about prioritization. Well, if it's a Bauer section, like fresh post-op, I don't know about you, but we're slicing and dicing people, okay? Has anybody got to go to their who's got to go to peri-application? If you have been to peri-application, you should never, ever, ever, ever question pain in a post-op patient again in your life, right? Why is that? They're ripping, they're tearing, they're flipping, they're flopping. They literally get out a saw and just start cutting off bones, okay? It's pretty intense, right? That's why you ever think about that and you're thinking, gosh, dog, we're screwing, we're nailing, we're hammering, all these things. That's why those patients hurt. That's why they hurt. So we do have to kind of be mindful of that. Okay, we're going to have to move on or we're going to run out of time. Okay, because I got a concert to get to, y'all. I got to go home. I got to get dressed. I got to put on a concert outfit. And then, yeah, feed the horses. Put your hair. Okay, all right. So let's talk about reactions, okay? So what you do need to know is you do need to know on there, let's go to this one right here. There are several different types of reactions. Regardless of the reaction, what's the first thing you do? Stop it. The only difference is if you think your patient is having fluid overload, we're going to slow the transfusion way down, because it's basically fluid overload volume, right? I'm going to slow it way down, and I can kill two birds with one stone. I can still give them the blood, but then I can get that doc on the phone and I go, hey, this patient's really sounding like there's some fluid overload. They're respiratory distress, they got some traffic going on, I don't like this situation. I put them on some oxygen, I really think they need some furosemide. Then I can give them some furosemide and I can pull that excessive fluid off, fair enough? But is there any reason that I can't keep giving the blood? I just don't have to give it at a slower rate, right? Okay? Because they're not actually having a reaction. The reaction means the body and the blood are not agreeing. They're not seeing eye to eye, okay? And so I don't care what the reaction is, you stop that blood. Okay? You stop it, and then you go on and you finish reassessing your patient. Okay? Is your patient complaining of wheezing? Are they complaining of shortness of breath? Are they complaining of their face is flushed and they got a rash and they're itchy? All those signs of allergic reaction, okay? Are they febrile? Did your patient spike a temperature? Okay? If your patient came in and they were 98.1 and now they're 102, is that a problem? Okay, but let me ask you this. What if your patient, when you started, was already here for an infection anyways and they need blood? What if they're septic? And they have a temperature of 101.5 and you checked it in 15 minutes and their temperature is 101.9. Are they having a reaction? They started with a fever, the blood isn't what caused the fever. Does that make sense? Right. You are going to have patients that way. Let me ask you this. Hemorrhaging, for instance, trauma patients. Okay, you got a trauma patient you're giving blood to. Heart rate is 140. Okay, blood pressure is 90/50. Okay, respiratory rate is 28. All right, that's what you're starting with. 15 minutes later, heart rate's 135. Blood pressure is still 90/50. Respiratory rate's 26. Are they having a reaction? No. Do you do anything about it? No. Because what am I looking at? I'm looking at that trend. If my trend is the same than what I started with, I'm not having a reaction. I'm just still rolling with the initial problem is. And that, do you think that's what happens in real life? Oh yeah. We don't just usually give them blood to people that are well. There's issues. So those vital signs, a lot of times they're not going to be normal. I'm looking at the change. Yes.
I think we talked about this the other day, but I can't remember what we landed on. If they're having a reaction from like blood, do you take the IV out or no?
Okay, fantastic question. Okay, so let me ask you this, all right? If you are having a reaction from the blood, what is going to happen what would make you take the IV out? Is it the IV site?
I mean,
It's the product, right? So it's kind of one of those that's a catch-22. If I have another IV, would I take that IV out? If I got another access. If I don't have another access, would I take that out?
No.
If I got a patient that doesn't have any other options for an access, would I take it out? So what could I do? I would stop the blood, I would disconnect the tubing, and what you can even do is if you wanted to preserve that little bit of blood that's in the hub, what could I do? You know what I'm talking about, the little connector that actually connects to the plastic cap one? I can change that out. I can take that out. So now, do I have anything that has that blood connected to it? All new fresh stuff, right? I put it on a little connector. I change out and I get some new IV fluids with new tubing. Okay? Because the odds are is the blood, the vein where that IV side is at and that blood is going through, is that blood still there? Is it still there or is it moved on? It's moved on. It moves on with every heartbeat, right? So if I don't have an option, I'm going to preserve my IV. But I can do some things to minimize that blood that they had a reaction with. If I got an extra site, I'll take it out because I got nothing to lose, right? But the reason I say that is you got to be very careful what you wish for. Because if you take out a difficult patient that already has difficult getting IV anyways, are you going to get another one? And now, what do I got to deal with? Now I got to deal with this reaction problem, right? And now, do you think it's going to be easy to deal with this? Because I might have to give some meds. For instance, if they're having an allergic reaction, what do you think you're going to give? I'm going to be giving some IV diphenhydramine. I'm going to be giving some IV Decadron or some methylprednisone, some kind of solvent like Medrol, right? I may need to go with some epi if they're having an anaphylactic reaction. Do I want to get rid of my sole lifeline? No. Okay, so that's a very good question because it's all based on what you got going on. If they're febrile, if they spike a fever, they got chills, all these things that suggest they're having a febrile reaction, now what do I got to do? Now I got to draw some blood cultures. I got to send that bag of blood down to the blood bank, right? Okay, I got to get some antibiotics started. So I'm not going to give up my lifeline, okay? Hemolytic, you're not going to see as much, okay? You're not going to see that one as much, but you know that it's there, okay? But the biggest thing is that you know what you're going to do. You're going to stop that transfusion, you're going to assess your patient, and you're going to roll with it from there, okay? All right. We're going to get through all of that. I don't want any more of that. Okay, fluid overload. You guys know what to do with fluid overload. If they got signs of fluid overload, you guys know what you're supposed to do. Sit the head of that bed up. Slow the transfusion down. Put them on some oxygen, and we're going to get an order for some furosemide. Okay? Okay. Well, I don't have a whole lot of time to roll through some of this. Okay. All right, let me look through here then and let's see what I think might be pertinent. Not that it's all not important, but let me kind of see what I think, because I was in here for some of this the other day that Dr. Price did. You guys know about bowel obstruction? What bowel obstruction is usually caused from constipation with these patients, especially because cancer patients are getting what a lot of? A lot of pain medication, which are opioids, and opioids, the most common complication with that common complication is what? Constipation that leads to that, absolutely. Okay, so that we can fix that with some stool softeners and some water, right? Okay? The calcium, I remember her talking about that with the high calcium. The best way that we fix that is how? IV fluids. Hypercalcemia, high IV fluids, we're going to basically filter that on out of the blood system. Okay, pericardial effusion and tamponade. I feel like I might have talked to y'all about this in cardiac. Didn't I teach you about this in cardiac? Didn't we talk about that? So, pericardial effusion or cardiac tamponade is just an increase in fluid in that pericardial sac. Remember we talked about that? And when we have fluid in that pericardial sac, the heart can do what? It can't pump, and if it can't pump, we don't have cardiac output, right? So what's the solution to that? The pericardial cathesis. That's right. That's where I got kind of all worked up about having to take a 3-inch needle and hook to the syringe, and I'm going to draw that fluid. You are not, the doctor is, let's get that straight. I don't need you in there going like, Dr. Glenn said I could take this needle and poke it in that heart. You're gonna put that pericardial sac. You know what I think of every time I think of that? Pulp Fiction. Anybody seen Pulp Fiction? I think of that. I surprise you every day, don't I tell you? Every day. One of those classics. Yeah. When she's having that cocaine reaction, that's Bernard. That's nasty right there. So I'm gonna, yeah, so we're gonna do a pericardial centesis, where they're gonna go in there and they're gonna draw that excessive fluid off the heart so you can pump. Pleural effusion, that's the one I talked about the other day, or where Dr. Price talked about the other day, and I elaborated. And they can go in there and they can do a thoracentesis. This is the thoracentesis right here. They'll go in there and they'll drain that excessive fluid out. And if it keeps being repetitive, that's where I was talking about putting in the chest tube till we get it resolved. Spinal cord compression, all right. Same thing, the tumor starts putting pressure on it. They're going to start having some of those neurosymptoms like she talked about. Radiation is kind of the big thing. We use radiation and chemo a lot as just a therapeutic component, trying to shrink this thing to where it makes things work better. Same thing with the superior vena cava. Okay, remember with the superior vena cava syndrome, this is where that tumor, and I've actually seen patients with that before, goes in there and wraps around, right? Wraps around and puts pressure on that superior vena cava. Why is that a problem? How does blood get into the heart? Through the superior and inferior vena cava. So do you think that's going to decrease my blood flow? Now, why do you think it's kind of especially up here in the face? Because remember, the superior vena cava gets blood coming in from all up here, okay? Versus the inferior is more from the below side, okay? But it's going to put pressure on that. It's going to decrease the amount of blood that goes into your heart, which is going to result in my what? Decreased cardiac output, right? So my organs are not going to get the blood supply they need. So same thing, we can do radiation or chemo with the goal. We can't surgically remove this. They will not touch that. That's not a candidate. Because if we nick that vena cava, what's going to happen? They're going to hemorrhage within a matter of a few minutes. So it's not an option. So we will actually go in and then we'll actually do radiation or chemo just to shrink it. Tumor lysis, I do recommend, I'm not going to go through this whole slide, I do recommend though that you understand this, okay? That high potassium, that low calcium, right? High potassium, low calcium on there, all right? And that you do recognize, we're going to stop the chemo or the radiation and these are going to get IV fluids, okay? So I do want to make sure that you can recognize that. All right, we're not going to go. What's the big thing that you guys know? We've talked a lot about CT scan. What's the thing about MRI that's most important? Who can go to an MRI?
Metal in the body.
No metal in the body. They can't have any metal on them or in their body. There's actually this very long questionnaire that they have to check boxes in order to actually be rule qualified to be able to have an MRI. So if they've had some prior ortho type stuff like metal plates and screws and stuff, they're not eligible for an MRI. Okay? All right. Radiation, we talked about the brachytherapy. You guys remember with the brachytherapy, it's radiation pellets. So when you're taking care of a patient with that, you make sure that you have what? That you have safety equipment, and that in the event that some of that any of this stuff happens to fall out, do you touch it with your hands? No, you're going to do some long toms. That's part of the safety part. And there's usually a container to put that in, right? And that you limit how long can you be in the room for? 30 minutes or less. Absolutely. That's at any given time. Okay? All right, let's go through here. There's the brachytherapy stuff. Let me get back to this stuff. More on the chemo side. What I want you to know, anything chemotherapy, because it kills off the cancer, and because it kills off the cancer, it also kills off the normal blood cells, right? We make these patients very neutropenic. What's the most simplest way to know your patient is neutropenic? White blood cells. You look and they got almost nothing, right? You look and they almost got nothing, okay? So any of these patients that's on chemotherapy need to be on neutropenic precaution. And all that is what? Protecting them from you. So, limiting visitors in the room. You wearing gloves, gown, and mask every time you go in there. Why would you want to leave them the equipment in there with them.
You don't want to share it.
Because I'm not rolling it from room to room. Am I likely to give something to them that way from another room? Yes. So we leave some of that same stuff in there. No plants, no flowers. We don't want raw fruits and vegetables that come out of the ground. No cats and cat litter, right? All those neutropenic precautions, okay? Also, can these patients, this is a good question, can these patients get their annual flu vaccine and their pneumococcal vaccine? I like it, no live virus, so yes, you can get the flu vaccine, but they need to know where they're getting it from, that they're getting it with no live virus version, okay? So, because it's just antibodies and it's not an actual live virus that they're giving, so that's key, but they do need those, because it's to help them build some antibodies to help protect them from the event that they come in contact with it. No large crowds, they don't need to be going out into public, right? Hold on. Do what?
They need to go to concert.
They don't need to go to concert? If I take it to somebody else, so, probably, oh yeah, get concert on my mind. All right, the other thing is treating, I've been practicing my singing on the way home. Okay, all right, the other thing is treating things like nausea and vomiting, right? If these patients are gonna be extremely nauseous or vomiting, we need to treat that, right? We need to treat that with medications, and we need to teach them the foods that they can eat that will help with that, right? Some of those things that we talked about, like things that have usually like, the problem is like a lot of times what helps resolve nausea, foods that have salt, right? So like crackers or some broth, but what can they not have it if they have what? If they have the glossitis or the stomach, remember the ulcerations in the mouth? That'll set them on fire, buddy. But why can't we gargle the salt water? Because it's then what? It's diluted in a water. Does that make it's diluted? It's not direct salt on the wound, okay? On there. So we can use that for those types of things. So we need to make sure we're treating that. These patients are also a high risk for nutrition problems. Remember we talked about that they may have a PEG tube or a G tube put in to be able to give them internal feedings, boluses as needed so that they can get the nutrition. What's the most important nutrition that they need? Protein. Where do we find protein? Meat. Absolutely. What kind of meat? I don't care if it's red meat, fish, chicken, eggs, or whatever. You better know your protein foods. I can tell you that.
But does it say avoid
It
red
said
meat?
avoid, yeah.
Where are we
Down
at?
in the bottom.
I
Yeah,
can't even. What?
That's down in the very bottom, bottom right. Bottom right.
Says reduce metallic
Well,
taste.
yes, but you can still have, I mean, red meats is like, are you planning on buying some ribeye or what, okay? So we can go a little bit,
That's what they're feeling nauseous.
yes, yes.
Okay.
But what's the safest
how it
protein bet?
Chicken.
Chicken.
Fish.
You can't go wrong with chicken unless you show up at the wrong joint, and then you can, right? Okay. That can really catch up with you for that round, okay? Yeah, you can't get some wrong. The chicken is the best source of protein. Okay, I'm trying to catch some of these things on here. We're gonna talk about hair, wigs, and all those great things. We talked about the mucositis and the stomatitis. We talked about no mouthwashes with alcohol, okay? So it has no alcohol-based mouthwashes, and the gargling with salt water does help with that. No spicy and salty foods that have direct contact on there because it'll increase the, all right? And these patients, you already know your thrombocytopenia for that, okay? We talked about this right here, right? Monitoring those IV sites very carefully because they can cause some pretty significant issues with tissue damage if it infiltrates. And if we suspect, if a patient says, my arm feels funny, it feels like it's really hurting and it's burning, what are you gonna do?
Stop it.
Stop it. You can never go wrong with stopping it. Because even if I discover that there's nothing wrong with this IV, I can always start it back. But if you keep rolling with it and there's something wrong, I can't, remember that, what goes in, I can't take back. Okay, once I give it, I can't take it back, okay? All right, we've kind of already talked about some of this on there. Okay, all right, I think that's kind of most of it. I will